We now move to steroid contraception. There are many different forms of steroid contraception. There are the progestin-only methods, and there are the estrogen plus progestin. Progestin is a generic term for a synthetic progesterone. Many of these are made of levonorgestrel. And the mini pill, which is the pill taken every day, is one of those. There are a number of trade names of RET. This needs to be used every day at exactly the same time. You cannot skip a day. You don't take a week off, such as you do for the combination pill. And this works primarily by affecting the cervical mucus to make it unfavorable for the sperm to get in. The intramuscular injection is the depomedroxyprogesterone acetate. This is Depo-Provera. It is given once every 3 months. We'll talk about that in just a little bit. The subcutaneous implant used to be Norplant. It is now come in as a different form. Instead of 6 silastic rods, it is 1. This is called Implanon. Then there's a morning after pill. If plan A fails, what plan do you go to? You go to plan B. This is also known as emergency contraceptive. And then there's the intrauterine device, also known as intrauterine system, which is a levonorgestrel IUD named Mirena. Then we have the estrogen-progestin combination. There is a traditional pill which you're very much familiar with, 21 days on, 7 days off, so there's 3 weeks out of 4. Then there is a new formulation, which is the pill which is given for 12 weeks straight, and then 1 week off for the withdrawal bleed. There was the intramuscular injection, Lunel, which was estrogen plus progestin. This is no longer on the market. Then 2 of the newer ones are the transdermal patch, which is Ortho-Evra, we'll talk about that, and the vaginal ring, which is the Nuva ring. Here's our case. A 44-year-old gravid 4 para 4 has questions regarding contraception. So she's in her later reproductive years. She uses a diaphragm, but is worried about failure. Now, how much do you think she needs to be worried about failure? What is the fertility of a 44-year-old? Really markedly reduced, and I'll show you some numbers on that. She probably doesn't require a very effective form of contraception. She's concerned her menses have become slightly heavier and more painful. Is there a form of contraception that can decrease the amount of her menstrual flow? Answer is yes. The combination steroids will do that very nicely. She doesn't smoke, and that's important because if she was over 35, which she is, and is a smoker, then the estrogen-containing pill would be contraindicated because of the high risk of thrombosis. This chart looks at the fecundity, which is the likelihood of conception with 1 month of unprotected intercourse at various ages of the female partner. And you can see at age 20, the likelihood of conception is 20%. At age 30, it is 15%. At age 35, it is 10%. At age 40, it's 5%. At age 45, it's only 1%. Which means that at age 44, her fecundity or likelihood of conceiving is almost 20 times less than at age 20. So she doesn't need a highly effective form of contraception. How do steroid contraceptives work? They work on various levels of the hypothalamic pituitary ovarian endometrial axis. So we can start with the pituitary. This is suppression of the LH surge. Estrogen and progestin both can suppress the LH surge. You have to have a fairly high dose of progestin to do that, but both can. If there is no LH surge, there will not be any ovulation. And so the mechanism is really combined here together. Estrogen and progestin will prevent the LH surge, and you'll have no ovulation. If you don't have any ovulation, you're not going to have any conception. They can also work on the level of the endometrium by producing endometrial atrophy. That is primarily by the progestins. Many of the contraceptives, particularly the progestins, will change the cervical mucus to where it is hostile for sperm to make their way up, make the cervical mucus thick and sticky. All right, metabolic products and concerns. The main thing you need to know is estradiol, which is the natural estrogen, is not orally effective. So all oral contraceptives use ethinyl estradiol. And ethinyl estradiol is a synthetic estrogen. The main thing to remember in terms of metabolic effects is that estrogen-mediated medications increase the risk of venous and arterial thrombosis. Progestin do not have any effect. So if a patient has had either a stroke, deep venous thrombosis, pulmonary embolus, lupus, they should probably avoid an estrogen contraceptive because of the risk. There is no problem, however, if they take progestins. The other thing which I would point out is estrogen stimulates a healthy lipid profile because it increases the HDL and decreases LDL. Progestins actually, they counter the beneficial effect of the estrogens. They will increase the LDL and lower the HDL. And when we talk about postmenopausal hormone replacement, you will see that progestins will decrease the beneficial effect of the estrogens. Contraindications are reasons why not to use the preparations, and the absolute contraindications include pregnancy. Obviously, if you're pregnant, there's no point trying to prevent it because it's already too late. Acute liver disease is a contraindication for both estrogen and progestins because the liver is the way these substances are removed from the body. If the liver isn't functional, you can have high levels which are dangerous, which develop. The history of vascular disease, emboli, deep venous thrombosis, cerebrovascular accident, lupus, this is primarily a estrogen contraindication and is not true for the progestins. If you have hormonally dependent cancer, breast cancer, which has progestin, estrogen receptor positive, obviously that would make sense not to use them. There are many benefits to steroid contraception which have nothing to do with contraception themselves. These are the non-contraceptive benefits, and most of these are related to the progestin component. There is decreased primary dysmenorrhea. Remember, primary dysmenorrhea is where you have an exquisite sensitivity of the myometrium to prostaglandins, which are released by the endometrium when progesterone falls. If you maintain a continuous level of progestin, you will suppress prostaglandin release. So you can do this either by nonsteroidal anti-inflammatories or by continuous progestins. DUB is dysfunctional uterine bleeding. This is, in most cases, synonymous with anovulation. Anovulation is where you have only estrogen, you don't have any corpus luteum because there's no ovulation, and so you have hyperproliferation and a thickening of the endometrium, leading to irregular shedding and bleeding. The progestin will stabilize the endometrium, and you will not have the irregular shedding and the unpredictable bleeding, which occurs with DUB, dysfunctional uterine bleeding. There is decreased PID because the progestin thickens the cervical mucus, makes it hostile for not only the sperm, but doesn't allow ascending bacteria, which go up into the tubes and ovaries and cause PID. And if you have less PID, you have less ectopic pregnancies. So these are many of the non-contraceptive benefits. There's another one which isn't on here, and that is they reduce the amount of menstrual blood flow. So you have less iron deficiency anemia, which is 8 times more common in women than men anyway. When we look at oral contraceptive pills and the risk of cancer, there are many, many benefits. Ovarian cancer, as we talked about before, is related to the number of lifetime ovulations. That is the epithelial ovarian cancer. Oral contraceptive pills, in many cases, will decrease the ovulations, so you'll have less risk of ovarian cancer. 50% reduction. The epidemiologic data also suggests that endometrial cancer is reduced up to 50% in women who have had a prolonged use of oral contraceptive pills. This we didn't talk about at all. This is something that internal medicine will probably be discussing at some length, is oral contraceptive pills decrease the risk of colon cancer, colon carcinoma. Now, statistically, cervical cancer is increased, but let's look at the reasons why that might be. If you have two groups of women, one that uses steroid contraceptives, the other one that uses barrier contraceptives, and recognizing that cervical cancer is produced by HPV, which group do you think will have the lowest HPV and which will have the higher? Well, the women who use barrier methods will obviously have lower HPV and will have a lower risk of cervical cancer. Does that mean that the oral contraceptives increase the risk of cervical cancer? Probably not. It's just that they don't have the protection which the barrier methods would to HPV. There's been a lot of studies looking at the risk of breast cancer and oral contraceptive pills, and some of the older studies suggested that there was an increase. The newer data suggests that there is no effect whatsoever. This is a large United States study which was looking at case controls with 4,500 women in each group, and they found no link between oral contraceptives and breast cancer. If we look at the data, and here we have an odds ratio of 1, which is about an average risk, which is blue. If we have a point above the line, that is increased risk. If it is below the line, it is decreased risk. And what we're looking at here now is risk of breast cancer by type of use. This is a risk in women who have never used oral contraceptives. This is women who have used any time. This is current users. This is former users. And you can see there's no significant difference at all. They're all a relative risk of 1. This is looking at the risk of breast cancer as a function of duration of use. Never used, less than 1 year, 1 to 5, 5 to 10, and so on. And you can see they're basically all 1, no difference. This is looking at the risk of breast cancer in women who used high estrogen oral contraceptives and low estrogen, which is what we use today, and you can see there's no difference as well. So this is fairly convincing that there is no impact of oral contraceptive use on breast cancer in women. All right, let's look at some specific steroid contraceptive modalities. We're going to start with the oral pills. These are the ones that you're well familiar with. 3 weeks on, 1 week off. The failure rate goes up as the woman's body mass index goes up. So women who are obese will have a higher failure rate, particularly with the lower dose pills. This is an interesting one which is now available. It is birth control in good taste. It is a chewable version of Avcon 35, which is a low-dose pill. This looks at the risk of oral contraceptives with varying ages of the woman based upon if she is a smoker or not. And you can see once you get age 35 or above, the risk of oral contraceptive pills with people who smoke is markedly elevated to the place where we shouldn't use them. Let's look now at the new formulation of the estrogen plus progestin combination pills, which have 24 days on and 4 days off. The initial one which was used was called Yaz. This is a unique one because it uses a progestin, which is drospirenone. The drospirenone and ethinyl estradiol is now available and has been approved by the Food and Drug Administration for premenstrual syndrome. What is unique about this pill is that rather than being 21 days on and 7 days off, it is 24 days on and 4 days off. And the reason for this was that the study showed it was the pill-free interval which resulted in a significant increase in the symptoms that women had with premenstrual syndrome. And by increasing the hormone days to 24, it markedly reduced the recurrence of these symptoms. So we have the 24 days on and the 4 days off. The drospirenone also has anti-mineralocorticoid activity, so there is less fluid retention, and it is anti-androgenic, so you have less of the acne which can occur with some of the more progestational formulations. Of course, there has to be a competitor, and the competitor is low estrogen 24. This has also 24 days of the pill, low dose, and 4 days which is off, and they have put iron in these 4 days off. I think that's more of a marketing device than anything else. Okay, then we have another new formulation of the estrogen plus progestin combination, which is the extended cycle. The FDA approved in 2003 the extended cycle oral contraceptives. These are taken for 3 months straight, and then you have a withdrawal period. Instead of having then 12 or 13 cycles a year, you only have 4. 1 every season. And that's why it's called seasonal. Fewer periods, more possibilities. And this is levonorgestrel, which is the progestin, and ethinyl estradiol is the estrogen. You can see we have 3 months supply, and then you take 1 week for the withdrawal bleed. When you compare women today with women, say, 100 or 150 years ago, today's women have 3 times as many lifetime menses as our early ancestors, because back then, the age of menarche was later, many, many babies, many pregnancies, long duration without any menses, prolonged lactation. And so the average woman probably had about 150 lifetime menses. Today in our society, most women will have about 450. So, which is more natural? Is it more natural what happened 150 years ago? Or is it more natural to have 450 ovulations? Well, we get into philosophy there, and I think we'll leave that to the philosophers. I think there's a lot of benefit to that. This slide puts into perspective the risk of venous thromboembolism with oral contraceptive pills. Now, there is no question that there is an increase if women who are on oral contraceptive pills than if they're not. But if we look at that in relationship, what is the risk of mortality of venous thromboembolism in pregnancy, and compare what is the risk of death from accidental poisoning, you can see that the risk of oral contraceptive pills is really pretty low. And if you want to put that even more perspective, the mortality rate in reproductive age women of a motor vehicle accident is 120 compared with 3 for oral contraceptive users. So, relatively safe, particularly with the lower dose formulations such as we have today. Then we have the IM injection. This is the trade name Depo-Provera. You will see on the exam, they will use generic names, which is depo-medroxyprogesterone acetate. She can take the pill 1 day at a time, or winter, spring, summer, and autumn. Isn't that romantic? Every 3 months. What should you know for the boards? The most common reason why women stop using Depo-Provera is irregular, unpredictable bleeding. And they need to be informed that this is quite likely to occur. It's probably because of endometrial atrophy. It does not affect the successful contraception. Another is it may take a prolonged period of time for return of fertility. And I'll show you it may be up to a year before a woman is fertile again. Concern particularly in adolescence is decreased bone density And then the cumulative weight gain can be significant if used over a long period of time. This is in 2004, and the Food and Drug Administration issued a warning for Depo-Provera users. And what they said was women who use depomedroxyprogesterone acetate may lose significant bone mineral density, which may not be completely reversible. And what happens is, normally when you take your combination pills, you have suppression of gonadotropins, FSH, and LH. And so the ovarian production of estrogen goes down, but you're supplying the estrogen with the pill. And so they have enough to maintain bone density. Particularly in the first 2 years of the Depo-Provera use, you're going to have suppression of gonadotropins, but there is no estrogen which is added. So as the gonadotropins are suppressed, the estrogens go down, and what happens to bone mineral density? Decreases. And that was particularly of concern in adolescents, because the peak bone mineral density occurs around 25 to 30 years of age. And if you don't get it as high as possible then, as the years go by, you may end up with earlier osteoporosis. So the Food and Drug Administration said, use the DMPA only if long-term birth control methods otherwise are inadequate, and try not to use it more than 2 years. However, this is a study in 2005 which showed that teens do lose bone on Depo-Provera, but they recover it after stopping use. So my suspicion is that the long-term hazard is probably minimal. This slide looks at the return of fertility, and this is looking at the number of months and the pregnancy rate. You can see after 6 months, 50% of women got pregnant. After 10 months, 75% did. But see, after 10 months, 25% of women still had not been able to conceive. So if a woman says, I want to put off pregnancy for maybe 3-4 months, don't use the DMPA. Use something else. Because you can see after a year, almost 20% of women still were unable to get pregnant. This is from the physician's desk reference, the PDR, and it shows the cumulative weight gain with women who use Depo-Provera for a long period of time. And you can see after 6 years, 16 pounds. I suspect not too many women are happy to have an extra 16 pounds that they carry with them. This I thought is interesting. DMPA may curb the spread of breast cancer. And this is particularly for those who have a breast cancer, which would be progestin sensitive. The IM injection, estrogen plus progestin combination, was known as Lunel. This was medroxyprogesterone acetate and estradiol cypionate injectable. The reason it was called Lunel is because it was injected every month. It was injected once every moon. And another term for moon is Luna. So Lunel. This is no longer on the market in the United States. The progestin-only subcutaneous implant, which used to be called Norplant, is not available, but in its place are 2 new ones called Implanon and Jadel. Norplant was removed off the market in the year 2000. Norplant had 6 silastic rods, which were placed subcutaneously in the skin of the arm. You can see the relative size. This is a 25-cent piece, a quarter, which is beside them. The Norplant was effective for 5 years before it needed to be removed. The difficulty was there were 6 capsules, they were small, and they weren't always easy to find. And so it would take a prolonged period of time, often to remove it. You have to dig around. People got upset. When people got upset, they're not happy, what do? They sue. And so you had law firms which took up the challenge. Do you have a claim against Norplant? And basically the company said it isn't worth it. And they withdrew it. So now we have available a single rod, 40 by 2 millimeters, called Implanon. And this shows about the size of this single rod which is placed. It is etonorgestrel rather than levonorgestrel. This shows where it is placed, right, and the junction between the dermis and the adipose. It is placed with this instrument that you can see here, and insertion time takes about a minute. Removal takes 4 minutes. So easier to find because it is a single rod as opposed to the 6 which were with Norplant. There is a competitor which is also coming along, which is called Jadel. This has 2 silastic rods. You can see they're almost 2 inches long. These are containing levonorgestrel, which is the same product as the Norplant. This is good for 5 years compared with the 3 years for the Implanon. And I think there's a lot of value to these. I think they're going to go and be very successfully used. This I thought was interesting. Koala bears in Australia were going to be implanted with the Norplant in order to prevent their reproduction because they were eating too many of the eucalyptus trees. So rather than get rid of the bears, they just keep them from reproducing. Another progestin only is the morning after pill. This is called Plan B. Its competitor, the name is Preven. This is also known as emergency contraception. This is levonorgestrel. If Plan A fails, which plan do you go to? Plan B. Now this is also known as a morning after pill, but it really isn't a pill. It is 2 tablets, which are taken 12 to 24 hours apart. 90% successful in preventing pregnancy. I chose a condom, but it broke. Now I have a second chance. Plan B, when things don't go as planned. The Food and Drug Administration panel recommended that Plan B available over the counter. This was the advisory panel. And usually advisory panels are listened to by the FDA. In this case, the FDA rejected the panel's recommendation, and my suspicion is that those who viewed this not as a contraceptive, but as something which prevented implantation after conception had occurred, they were against this. The argument for not allowing it was that there wasn't enough data on 14-year-olds using it. Well, the company came back, and the FDA has now approved Plan B over the counter for those 18 years old or over. My suspicion is it will be soon released for everybody. Walmart initially didn't want to carry Plan B. I suspect probably for some of the same reasons that they were concerned about that it may cause early abortion. Of course, that's a matter of definition. But the company was sued in Massachusetts, and the court said they had to carry it. And so now Walmart does carry it throughout the country. This is the competitor. It's called Preven. This is levonorgestrel as well, but it also has estradiol. And the estradiol can give nausea, which is probably not going to be as well tolerated as the Plan B. When all else fails, it's not too late to prevent pregnancy after sex. Now, some of the new steroid contraceptive modalities include the combination estrogen plus progestin vaginal ring and the combination estrogen plus progestin skin patch. Let's look at the vaginal ring. The trade name is Nuva Ring. This is the ring. It is about 2 inches, 54 millimeters in diameter, and 4 millimeters thick. It fits into the vagina, not necessarily like a diaphragm, which has to be properly placed, but anywhere in the vagina where there is contact, where it can be absorbed. And you can see it's quite effective, 6 pregnancies per 12,000 cycles. You can see here how it is very soft and very flexible. This is etonorgestrel and ethinyl estradiol. I want to show you the difference between the mean ethinyl estradiol levels between the oral contraceptive pill and the ring. The reason why the pill needs to be given every day, because even though you have an increased level, it drops very rapidly. And so you have this fluctuating level which goes up and down. Notice how the Nuva ring has a very controlled, gradual release, which then lets you have probably the same contraceptive benefit with less estrogen exposure. And this slide shows the average estrogen blood levels with the Nuva ring versus a commonly used oral contraceptive. So I think there's a lot of potential for the Nuva ring. The transdermal patch is estrogen plus progestin, also a combination. The trade name is Ortho-Evra. The patch is applied to the upper arm or to the buttocks. There are 3 patches which are given 3 weeks in succession, week 1, 2, and 3. Then on the 3rd, or after the 3rd week, you have a week off for the withdrawal bleed. Now, frankly, it doesn't seem to me that there will be too much difference between giving 12 weeks of the patch and then 1 week off, such as you would with the seasonal, and with the Nuva ring. Why couldn't you use the ring for 3 months straight and then have the withdrawal period? But this has not been approved by the Food and Drug Administration. Of course, you need to make sure that the patch stays on the skin, it doesn't irritate the skin. But this is one of the theoretical concerns. Notice the levels of the ethinyl estradiol over the period of 3 weeks. You can see that initially you have a significant rise, but then it falls, and then suddenly it falls off quite rapidly at 7 days. That's why you have to put another patch on. And I want to show you in just a bit, comparing the pill and the ring and the patch as far as the mean estradiol level. The progestin in the Ortho-Evra is a new one called norelgestromo, which is somewhat unique and different. So you have 1 patch applied weekly for 3 weeks and then 1 week withdrawal. This appeared in the New York Post in September of 2004, and the headline was, "Sex Patch Tied to 17 Deaths." Sex patch. That's called media for you. This is a contraceptive patch. Initially, this didn't get a whole lot of attention. It was thought to be just a media ploy. But then the FDA came out and said, maybe the patch does have blood clot risk. And what they looked at was the mean level of estradiol compared to the pill. And they said that women who use the Ortho-Evra contraceptive patch are being exposed to about 60% more estrogen than with a typical birth control pill, which could put them at high risk for blood clots. And of course, wherever there is a problem, there's always lawyers right behind. And so here we have the Ortho-Evra, injury.net, your local attorneys ready to help. When we compare the cost of the patch versus the ring, and then the Mirena, the levonorgestrel IUD, which we'll talk about shortly, you can see that there is an interesting pattern, which over time, the IUD is actually a lot cheaper. Even though you're paying less each month because of the duration of action of the levonorgestrel, Mirena, the annual cost is really a lot lower. Now, this is a slide I was alluding to. It looks at the mean ethinyl estradiol levels of the 20 microgram oral contraceptive pill, the Ortho-Evra contraceptive patch, and the vaginal ring. And what we're looking at is a level of 20 picograms. You can see that the ring is consistently at or below. The pill goes up and down above the 20 micrograms a lot. And yet the contraceptive patch, most of the time, is above the 20. And this is where they come up with the number 60% more exposure with the patch. And yet, I don't think it has been proven that this increases the risk of thrombosis, but you can see how theoretically it would be a concern. The patch is much higher. Why do most women quit using their contraceptives? And you can see the most common is irregular bleeding. And that is particularly true with the DMPA, dipomedroxyprogesterone acetate. Nausea, perceived weight gain, mood changes, breast tenderness, headache, but particularly it is the irregular bleeding. Okay, that is the end of steroid contraception.